Hello, this is Aditi Ambardakar with OpenAnesthesia.com and Anesthesia and Analgesia. I'm here today with Lauren Loba to discuss her article titled Medication Errors in Pediatric Anesthesia, a report from the Wake Up Safe Quality Improvement Initiative. It has been chosen as our article of the month for September's issue of Anesthesia and Analgesia. Dr. Loba is an assistant professor at the Department of Anesthesiology, Perioperative and Pain Medicine at Texas Children's Hospital and Baylor College of Medicine in Houston, Texas. Welcome, Dr. Loba.
Thank you.
To start, just so that we can give our listeners a little bit of a background, can you tell me about Wake Up Safe?
Absolutely. So Wake Up Safe was a component that came out of SPA, the Society for Pediatric Anesthesia, in 2005. And it was a pursuit to improve the processes and look at how we could make our outcomes and our overall care in children and newborns and infants better in the perioperative setting. So it started in 2005, and now many years later, it's had many improvements. And one of the things that started was a database where they could collect events, and all the institutions that participate in Wake Up Safe submit those events into this de-identified registry.
Great. So now that we understand a little bit about Wake Up Safe, what it is, can you summarize the study and the methods that your team used to get some information?
Absolutely. So in September of last year in 2016, as members of the Wake Up Safe committee, we submitted, and anyone can do this, submitted a request to Wake Up Safe to get data for research purposes. So we submitted that request to look at medication errors in the registry. And through granted access to this registry, you can pull out all of the events related to medication errors. And so we were able to pull those from the day of first collection until our last cutoff was in September of 2016. So we were able to look at all those events. It ended up being over a 6-year period because obviously when Wake Up Safe started, they didn't have the registry right off the start.
So can you discuss some of the advantages and perhaps maybe some of the disadvantages of using the Wake Up Safe database to help quantify and qualify medication errors?
Some of the advantages, I think, are that it's ease of use in terms of it being de-identified. It eliminates one of the things that's cumbersome about research is the IRB approval. Because it's de-identified and they went through an IRB approval process at the very inception of Wake Up Safe, you don't have to submit that paperwork and go through all that legwork to get this data, which is a nice piece, particularly with QI. It kind of eliminates that. The other advantage is that you have all of the member institutions that participate in Wake Up Safe submit this. So you're automatically getting access to multiple institutions across the country. So you broaden your scope. Instead of collecting the data from just your institution, you're able to look at what all institutions submit. So I think those are some of the biggest advantages of the database. The hard parts about using this database are because it is institution dependent reporting. Every institution reports things a little bit differently. Sometimes there's underreporting, and that can be there's scant information or people don't really get into the detail of the event that occurred, but also because it is self-reporting, not all events get reported, so you might not be capturing a true incidence. And that was one of the limitations we had because we weren't really able to determine incidence basis. We could just talk about the events that were submitted. So when you look at our paper and the numbers that we have, that's not at all meaning that that's the incidence of medication errors in pediatric anesthesia. That's just of what was reported.
So despite the limitations, your team was actually able to learn a fair bit about medication errors in this setting. Can you tell us a little bit about what your team learned from the database?
Absolutely. We found that of the medication errors that were reported most frequently, they occurred during the administrative phase of the anesthetic, and there were 2 types of events that happened more frequently than others, and those were administration of the wrong dose of medication and syringe swaps. And I think that that stood out to us, and I'll elaborate in a little bit about how you can target interventions to change that. The other thing that was powerful to me was that 80% of the reported medication errors actually reach the patient, and more than half of those cause harm to the patient. So when you're looking at the significance of reporting and whether we should really work on interventions to change this, that's a large percentage of patients that you are putting in harm. And now the harm was different categories, but I think that regardless, we set out as anesthesiologists to not harm our patients. And I think that this leaves opportunity for us to improve how we care for our patients. Another thing that stood out to us was that more than half of the errors reported involved infusions or drug pumps, which I think has come up in other medication error discussions about the vulnerability of the drug pumps that were used. And then the final thing I'll say that was powerful, and it kind of alluded to the harm to patients, was that nearly all the cases were reported as either likely or certainly preventable. And I think that that should stand out to listeners and readers of the article, that these are things that the submitting group felt like they could have prevented these events from happening.
That's really interesting. So as a pediatric anesthesiologist, I can understand how these drug errors can be made, especially while working with a trainee or under certain circumstances. Was there consideration for when the drug error occurred and what human factors may have been involved in the drug error? For example, were drug errors made mostly under stressful or crisis situations?
I think that that is very helpful in determining how you can set about interventions and improvements to eliminate those human errors. However, with the way the database is set up, it doesn't leave area for that to be included. So when you read these events, it doesn't always give the fine details, and it's variable, as I mentioned before, what gets submitted. So you can't really get that information from how Wake Up Safe collects the data.
So even though the study was done in the pediatric population or pediatric anesthesia practice, can you comment on how we can generalize what you've learned to anesthesiology as a field?
So I think that this is absolutely applicable to all anesthesiology. If you look at one of the papers that we looked at was the Nanji paper from 2016, and in that paper they stated that 1 in 20 medications administered involve an error, and that was in an adult setting. So I think that when you look at our paper, we kind of speculated that maybe pediatrics is more at risk for medication errors because we do weight-based dosing, and where an adult may just get 100 micrograms of fentanyl, children are 1 to 2 mics, and it's a very much smaller dose and more room for error in preparation. So I think that this paper can be expanded and applied to the adult setting as well.
What are some next steps your team or other teams may employ to understand how to minimize medication errors?
I think the most important thing that when looking at medication errors in your institution, you need to understand the culture that your hospital, your department has, and see if it's one that is willing to come forward with these events, and if not, what you can do to improve that. I think creating a culture that is open to reporting errors and feels like it's not going to be punitive is a big deal. A lot of discussion in safety and event reporting revolves around the feeling that you're not going to be penalized for these errors. And so I think that that plays a part in it. The other specific targeted interventions that we looked at or have talked about as a group in Wake Up Safe and our own group that wrote this paper were things like standardizing pre-filled syringes. Pre-filled syringes are prepared and supplied to the anesthesia provider by the pharmacy, so it eliminates that chance for error in preparation or syringe swap. So it can improve that. Another mechanism is labeling errors. A lot of institutions have utilized codonics or other labeling systems to properly label their medications. One thing that I think that we are waiting to improve upon is point of care barcoding systems that are integrated with our EMRs. Those are pretty costly and have some technological glitches, but I think that if they can be improved, show promise in eliminating the errors that we see. And lastly, I think a big thing that a lot of institutions across the country struggle with are the infusion checks. Anywhere outside the OR, infusions are checked by at least 2 providers to ensure safety, that the right medication, the right dose, the right patient, but that doesn't always happen in the OR. And I think that based on our findings, we need to take the time and the resources to ensure that our infusions are correct.
Thank you, Dr. Loba. That was really interesting, and we're grateful for teams like you that are trying to really make our patients be cared for in safer environments. Thank you so much for chatting with us today.
Thank you for having me.